You are 22, holding a mask on a stranger's face in an operating room. That hand pays $17.60 an hour. 12 years later, it pays $543,000 a year. She stopped breathing on a table in England. 4 people in the room knew what to do, and the equipment was already open. Nobody said it out loud. She died 13 days later, and that silence is the difference between the bottom of this ladder and the top. This is every level of an anesthesiologist's career, and what it costs to climb. If you want to see how these careers really pay, subscribe so you do not miss the next one. We start at level 1, the medical student. The medical student earns nothing an hour and nothing a year, and pays for the privilege. Most are 22 to 26. Tuition and living runs between $60,000 and $90,000 a year, and almost all of it is borrowed. In the 3rd year, you begin standing in operating rooms, spending a week or 2 on anesthesia holding a mask on a stranger's face while somebody tells you to move your fingers half an inch. Getting in requires a 4-year degree, the medical college admission test, and an application through a central service, and the average accepted student applies to between 15 and 30 schools. More than half of applicants are turned away without a single acceptance, and it is rarely the science. It is the 4 unpaid years that most people cannot fund. Here is what nobody tells you. The debt is the real entrance exam. Everybody who gets in is clever enough. The filter is who can afford to earn nothing until they are 27. Before the ladder goes further, understand what the word under actually means, because every wage above this rung is priced off it. 3 things are happening at once, and only one of them is sleep. The first is unconsciousness, from a drug pushed through a vein, and it lasts a few minutes unless it is topped up by gas or by a pump. The second is pain control, and it is separate. A body can be unconscious and still be responding to being cut, with the blood pressure and the heart rate climbing to prove it. The third is paralysis. Every skeletal muscle switched off, including the diaphragm. From that second, the patient cannot breathe, cannot cough, cannot swallow, and cannot signal that anything is wrong. A tube goes into the windpipe, and a machine takes over. That is the trade at the center of this specialty. To make surgery possible, somebody deliberately removes a person's ability to breathe, and then personally supplies it for 2 hours. The intern earns $17.60 an hour, roughly $64,300 a year. Most are 26 to 29. You are a doctor now, legally, with a badge that says so. You work between 60 and 80 hours a week, which is where that hourly figure comes from. You rotate through medicine, surgery, the emergency department, and intensive care, and most of what you do is paperwork, chasing results, and being called at 3 in the morning about a potassium level. Getting in requires graduating, passing the second step of the licensing examination, and matching. The match is a computer algorithm, and on one Friday in March, it tells every senior in the country where they will live for the next 4 years. You do not negotiate, and you do not choose. A small share of applicants do not finish the match with a place at all, and have to scramble for whatever is left inside a 2-day window. Here is what nobody tells you. This is the highest paid year of training per hour, because it has the most hours in it, and nobody living it feels rich. It is also the last year somebody else is responsible for what you do. The Anesthesiology Resident earns $19.10 an hour, roughly $71,400 a year. Most are 27 to 31. 3 more years, and now it is only this. You start with healthy adults and simple cases. By the 2nd year, you are doing hearts, lungs, obstetrics, and trauma. You learn to put a line into a neck vein using ultrasound. You learn to place an epidural in a woman in labor by feel. You learn to look at a waveform and know what is wrong before the number on the screen changes. Getting here requires the match again, a place in an anesthesiology program, and passing the basic examination of the specialty board at the end of the 1st year. A number of them do not finish the residency in the specialty they started. Some fail the boards, and most leave for a different specialty inside 18 months, and the reason is almost always the same. They cannot get used to sitting with the anxiety. Here is what nobody tells you. Residents describe this job as long stretches of monitoring broken by moments of emergency. And it is the long stretches that break people, not the emergencies. The ones who stay start asking for the cases that frighten everybody else. The cardiac fellow earns $22.30 an hour, roughly $83,200 a year. Most are 31 to 33. This is the strangest year on the ladder. You are fully qualified. You could walk out on the Monday and take a job paying $400,000. Instead, you sign for one more year at a training wage to do the hardest thing in the specialty. Cardiac anesthesia means the patient's heart is stopped, and a machine takes over the circulation. You run the drugs, the transfusion, the echo probe down the esophagus, and the moment where the heart is asked to start again. Getting here requires a completed residency, board eligibility, and a place at a center that does enough of these cases to teach them. Plenty of them are turned away at the fellowship match, and a good share of those offered a place still say no. The reason is money. The year costs about $300,000 in salary not taken. Here is what nobody tells you. Almost everybody who does it says the year was not about learning the procedure. It was about being in the room enough times to stop being frightened of it. And the Monday after that year is the strangest Monday in American medicine. The staff anesthesiologist earns $186 an hour, roughly $447,000 a year. Most are 32 and up. There it is. The wage rises by a factor of 9 across a single weekend. Nothing about your hands changed on the Saturday. What changed is that your name is now the one on the record, and there is nobody upstairs to call. The 9 is not paying for skill. It is paying for the answering. You run one room, or you supervise several, moving between them, present for the induction and the emergence, which are the two dangerous ends of every case. You decide whether a frail 80-year-old can survive the operation that would fix her hip, and you say it out loud. And sometimes you are the one who says no. Getting here requires board certification, a state license, hospital credentials, and malpractice cover that runs into tens of thousands of dollars a year. A steady share-leave clinical practice inside a decade, and burnout in this specialty is measured consistently above the average for physicians. Here is what nobody tells you. The difference between a good anesthesiologist and a great one is not skill. It is whether you will say the uncomfortable thing out loud, in front of a senior surgeon, in the middle of a case, when you are the only person who can see it. One thing has to come first, and it is not medical. It is about who is allowed to speak in an operating room. That room has a hierarchy, and it is old. The surgeon is doing the operation, and the room organizes itself around the surgical field. The anesthesiologist is at the other end, behind a drape, looking at a head and a monitor, which is a completely different view of the same patient. The person most likely to see a breathing problem first is facing away from what everybody else is watching, and outranked in that moment by the person holding the knife. Scrub nurses and technicians see a great deal, and in most rooms they are the least likely to say it in plain words. They will fetch the equipment. They will ring for a bed. They will put the thing on the trolley where somebody might notice it. The specialty now has a training course of its own on speaking up. There are grown adults with medical degrees being taught how to finish a sentence in front of a senior colleague, and there is a reason for that. On the 29th of March 2005, in England, a 37-year-old woman went into hospital for a routine operation on her sinuses. Her name was Elaine Bromiley. She was healthy, and she had 2 young children. At induction, the tube would not go into her windpipe, and then the mask would not move air either. This is the emergency the entire specialty trains for, and it has a name. Cannot intubate, cannot ventilate. 3 senior clinicians worked on her airway for around 20 minutes while her oxygen stayed critically low. The nurses in that room understood what was happening. One of them fetched the tracheostomy set. Another rang the intensive care unit and got a bed. Neither message reached the doctors. Nobody in the room said the sentence out loud. The tracheostomy was not done. She never regained consciousness and died 13 days later. Her husband, Martin Bromiley, was an airline pilot. He asked for an independent review of a kind hospitals did not routinely do then, and afterward founded a group that now teaches this case to anesthesia teams worldwide. It is not taught as a story about skill. The chief of anesthesia earns $219 an hour, roughly $543,000 a year. Most are 45 and up. You still work in rooms, but fewer. The rest of it is the schedule, the hiring, the drug budget, the contract with the hospital, and the phone call at 2 in the morning when there are 3 emergencies and 2 anesthesiologists. You are the person who decides which operating rooms run tomorrow, which means you are the person who decides which patients wait. Getting here requires years in the department, the trust of surgeons who did not vote for you, and a tolerance for meetings that would surprise the version of you who chose this specialty. A good many do not finish a full term in the post. Clinical work has an end to the day. This does not. Here is what nobody tells you. The chief is the one who has to defend a colleague after a bad outcome, in front of people who already have an opinion, and every chief will tell you that is the part nobody warns you about. 2 people out of this system earn more than the chief does. The first is the full-time locum, flown in to cover a gap, 26 weeks a year, at $2,600 a day, with no pension, no partnership, and no colleagues who know his name. The second is the pain physician who opens a practice and owns the building, because ownership pays what employment never will, along with payroll, billing, and the risk. Neither of them has to defend anybody at 2 in the morning. Medical student, nothing an hour, borrowing to be there. Intern, $17.60, 80 hours a week. Resident, $19.10, reading a waveform before it changes. Cardiac fellow, $22.30, paying $300,000 for the year. Staff anesthesiologist, $186, name on the record. Chief, $219, deciding who waits. More than half never get in at all, and a steady share leave inside a decade. That room in England had a surgeon, 2 anesthesia doctors, and 3 nurses in it. 6 people. At least 4 of them knew. Not one of them had ever been taught how to say it. Next, every level of an HVAC technician,